sick and tired of the high costs and inefficiency plaguing our U.S. healthcare system? Do you feel like you're navigating a maze when dealing with insurance companies, only to end up paying a fortune for basic medical services? Then this Broken Healthcare podcast is for you. So get ready to take control of your healthcare. Here's your host, Ray Kober.
And we're live, ladies and gentlemen. Welcome to Broken Healthcare. My name is Ray Kober. I am your host, and I'm delighted to have with us in the studio today, Charlie DiMaggio. What's happening, cuz?
Cousin, it is good to be here.
And yes,
it is nice to be here with you.
We are cousins.
Right. Yeah. It's so, in that sort of Italian, whatever that show is, The Bear, where everyone gets called cousin.
Exactly.
Yeah.
Exactly.
Yeah,
So
yeah.
just to kind of connect the dots, and I suck when it comes to this, like when it comes to figuring out, and Maria's great at it. So
Maria's fantastic at it.
Maria's great at figuring out, like, is it a second cousin? Is it a third cousin? How far removed? Like, her brain is just wired for it.
I have a list of names from when Liz and I got married 40 years ago that Maria made up for me with like a little cheat sheet of who everybody is. Liz just came across it the other day. But fortunately, ours is a lot clearer, you know. Yeah, exactly. You're married to my first cousin, so that makes you my cousin.
There we go.
That's it.
Exactly. Let's leave that there. So really appreciate you coming out. And so just to give the audience some background, I didn't have you on just because you're my cousin. If I did that, I'd have a show for years just interviewing cousins, especially on Maria's, the Davi side of the family. But tell folks a little bit about your background and what you do.
Okay, so I am an epidemiologist, specifically an injury epidemiologist. We study epidemiologies, epidemics, and I am a professor of surgery and population health at NYU Langone in the School of Medicine. Prior to that, I was associate professor at Columbia University in the Department of Epidemiology in the School of Public Health. Prior to that, I worked clinically as a PA in emergency medicine for Mount Sinai at Elmhurst Hospital Center in Queens. And along the way, I've had sort of like various gigs in public health. I was at the Nassau County Department of Public Health as a biostatistician for a couple of years. I worked as a PA at Rikers Island in the Rikers Island Health Service for Montefiore Medical Center for a couple of years, and there are a bunch of other sort of gigs. But right now, I mean, other than sort of like my clinical career now, I'm pretty much settled into an academic medical research career. And my doctoral training is at the PhD level. My clinical training is as a physician assistant. That's kind of like, where I am. And I've been doing it for a lot of years. And it occurs to me that much of what you might ask me or we could discuss, it might be of historical interest than anything else at this point. But it is an absolute pleasure to be here with you, right? This is very cool that you're doing
historical interest. Come on. Come on, Charlie. We're not that fucking old. Anyway.
Well, you're not, but I'm embracing it.
We're in the same ballpark.
Yeah.
So I want you to tell us a little bit about kind of your path, because it's fascinating to me, us humans, and I tell people all the time, I really believe that we're incredibly lucky. We all hit the lottery in terms of where we are on in the scale of human existence, of all the places to land and have this opportunity to live, to be in a free country and have all of the freedoms that we do and all the privileges that we do. If you're even if you don't have a home or a roof over your head, you have it so much better than so many other human beings on the planet. Just by chance, you landed here. And when you do have opportunity and you do have privilege, and I don't think it started that way for you, right? I know your background, not too dissimilar from my family's background, but your parents emigrated here from Sicily back in the day. They didn't come here with very much, but you were afforded an opportunity, and you really made something of yourself. Like, I'm not here to blow smoke. Like,
right.
it's it is your achievement is. I think amazing. I'm not going to sit here and call you a genius. I think that
Well,
I think
you
that's
shouldn't.
I think
Exactly.
that term is thrown around a lot. But and I have the privilege of interviewing some very, very successful people, and it intrigues me that some people just seem to go. They have another gear and they figure out a way. And when you look at the body of work and their accomplishments, it's amazing. And I put you in that category, but I want you to just take us back to, like, were you always on this path? Were you always a good student? Where did that come from? Was it I don't think your mom or dad beat this into you, or maybe they did. But where do you think that came from? Were you just naturally drawn to?
No, if anything, I don't think. I mean, there was always an emphasis on, trying to work hard and do the best you could. And I think that's. I mean, if you think about what our folks did, what my folks did. I mean, they were kids really, and they left everything they knew, and they came here. And they gave us this opportunity that we absolutely wouldn't have had. And you're right. I mean, if you think about sort of like where we come from, and I come across folks that have a similar story in New York more often than you believe. Really, like, there are folks that have the same. So I didn't even speak English until I was 6 or 7 years old.
I did not know that.
Yeah, they sent me to first grade in the New York City public school system, and not speaking a word of English. And I still remember it was like that. I mean, this goes back to the Peanuts cartoon where the teacher would speak, it would just go wah 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 wah, and that's kind of what I heard. But the New York City school system's response to that was, this child cannot be in this class because until he learns to speak English. So they sent me home.
Wow.
And at the time there was this. So we grew up on Elizabeth Street. This was in the 1960s. And there was this
Elizabeth
incredible...
Street's in Little Italy,
Yeah,
the
Little Italy.
little piece of Little Italy, downtown Manhattan. For those that may not be familiar.
Yeah, near Delancey. It's like, if you come to New York City and you decide to go to Little Italy, that's where you're going to end up. It's like right around the street from Old St. Patrick's Cathedral,
Right.
And where Martin Scorsese filmed Mean Streets.
Uh-huh.
He grew up on the same block.
Oh, wow.
Yeah, he may have been around at the time.
Shout out to Marty.
But it was this incredible sense of community because I was sent home and my family told everyone on the block, we can't speak Sicilian to Charlie anymore. You can only speak English to him.
Oh boy.
And I remember it was kind of traumatic. I would go to the grocery store or across the street to get like a little candy,
Right.
And they wouldn't give it to me unless I asked for it in English. But I learned how to speak English.
Wow. Wow. That's a trip.
And then beyond that, I mean, and beyond that, it seemed like a mission to me. I had to like learn.
Yeah.
I had that instilled in me.
Yep.
That and the fact that it's just incredibly everything I've learned is just incredibly interesting.
Yeah.
It's just like the world is incredibly interesting.
Yeah.
And you're absolutely right. There are few times, honestly,
Yeah.
in history where you would have been more fortunate to have been born. Few times in few places than in the United States in the 20th century. I think you're absolutely on the mark about that, right? I mean, it's just
100%. I
the
think
opportunities, and then there are other great places and other, but think about it. Essentially, like, if the timeline of human history
Yep.
were like the Empire State Building, we're kind of like on, like wherever the dirigible docked at the top there, and everything else was like dirt farmer, dirt farmer, dirt farmer, dirt farmer,
Right.
For your entire life.
Oh yeah.
Really.
It's insane.
Yeah.
Indoor plumbing.
Yeah.
Electricity.
Yeah. Although,
like,
you go back, I mean, like, in ancient Crete, they had indoor plumbing. And there's a cyclicality to it too. I mean, we can go down this road. This is interesting stuff. To me, this is anyway. This cyclicality, because I think we might be in one of these cycles right now.
Yeah.
Because I certainly know that from my training and from my schooling and from my experience, there's this sense that, there's this inevitable sort of increase in knowledge and wellness and just well-being. But that's not necessarily so. I mean, we forget things. We really do.
So what do you mean by that?
Well, what I mean is if you think about, let's say, certain civilizations, certain times in history, there was a great accumulation of knowledge, and then it was forgotten. And you see it happen, in and this has nothing to do with healthcare, but it's interesting. The Bronze Age collapse, for example. Nobody knows why. All of a sudden, everything kind of collapsed. And then you had the rise of classical Greece, and Hellenistic Greece. And there was this great accumulation of knowledge. And then you had the Dark Ages, and everything was forgotten.
Right.
And then you had the Industrial Revolution, and then you had the Renaissance, and then sort of things were kind of, and we've kind of been riding on the coattails of the Renaissance and the Industrial Revolution for a long time.
Yeah.
And, you wonder to yourself, are we at a stage now? Because there are people that are questioning what I consider to be foundational facts of well-being and life right now. And we need to think to ourselves, okay, it's not a given. It's not a given that things are going to continue to get better and better.
Right.
Like you said, I mean, we're afforded the opportunity right now.
Yeah.
We're fortunate.
Yep.
We need to take advantage of it.
Yeah.
Right?
No,
Yeah.
100%. And, I think we're learning more. And with the advancement of technology, like, for example, I was just watching a series on Netflix. The name of it escapes me. But they're doing research with new technology that allows them to see underneath the canopy of the Amazon, for example. And they've discovered these ancient civilizations that were built there, massive cities with populations in the hundreds of thousands, if not millions, that were highly advanced, that was kind of swallowed by the rainforest over time. And, only until recently have we had the technology like LiDAR and stuff like that for them to discover this. And so now they're saying that they're dating and tracing, our history in terms of humanity and civilization back much further than they originally predicted.
That's amazing. It's amazing.
It's crazy stuff. And so as it relates to, and I don't know that it relates, but epidemiology. Tell us what that is.
Well, I mean, epidemiology is the study of the movement of diseases and in human populations generally.
Okay.
And there's two main kinds. There's descriptive epidemiology, where we just say, okay, well, here's a number of people that get sick from this, and here's where they live. And then there's causal epidemiology, which is here are people who get sick, and here are people who don't get sick, and this seems to be the difference between those two. And we think that this factor, for example, whatever, smoking, is why this group of people get sick and this group of people don't get sick. So that's the two main things. To me, I think it's one of the foundational sciences in healthcare. Really, everything your physician or your healthcare provider does for you in most settings is based on an epidemiologic understanding of disease, of pathology. There's a couple of different things. It's also based on biology and pathology, and but in terms of giving you advice about how you should or shouldn't sort of should you exercise, should you drink alcohol, should you there's a lot of these questions now, and ideally they're based on evidence, and that evidence ideally comes from epidemiology. For many, many years, we just sort of accepted. Said, oh, well, here's the evidence. Here's what you should do. Do it. There seems like there's a lot more of a pushback on that, I think, in the U.S. and society. I think our most recent election sort of, exemplifies that. I mean, it just sort of puts that into stark contrast and relief. Some people are just saying, hey, I'm not sure I believe that. You tell me that I should get my kids vaccinated. I don't believe that. And I'm not, and actually I'm trying not to sort of put that in sort of a pejorative way. I'm not saying, okay, oh no, obviously you need to be vaccinated. I think that's a really interesting discussion that we're sort of starting to have now.
Well, let's talk about that a little bit. So I know that I wanna. You know what? Let's stay there, and then I want to. Remind me if I forget to talk about masks.
Okay, sure.
Regarding the COVID epidemic, but as it relates to vaccines, I think there's a lot of misinformation out there. I don't think there is a lot of misinformation out there, and people have difficulty, especially in today's day and age, where many people are getting their news from social media and Facebook and stuff like that. I think once upon a time, there was more faith in our news sources, you know, when you had the Walter Cronkites of the day and you had just editorial integrity amongst, you know, news publications, for example. Right. I don't think we're living in a day and age where folks trust the media. And I could tell you, I don't trust the media. And I do think it's important that, you know, maybe trust but verify and ask questions. And you know, we're living in a culture where people are villainized for questioning. And so I love that you're saying that you're not stating this in a pejorative way, because I think a debate is healthy.
Absolutely.
When it comes to vaccinations and putting stuff in your body. And so you're an expert.
Right, without a doubt.
Tell us what you think about.
I'll tell you, I mean, I think that, like I said, I think there are some foundational truths that have been proven without very much doubt. For example, that you know, like vaccine, like, you know, the problem is, like, you know, you make these blanket statements. Vaccines are safe and effective, and then you say, well, you know, which vaccines, how many vaccines, at what age, for whom?
Right.
You know, it gets more complicated.
Right.
And this idea of
one size fits all.
This idea of sort of, like, you know, of concern about the truthfulness of the media, it spills over into other areas. So, you know, there was a time when everyone just sort of trusted their doctor. I think they still do. It's really, that's something we should talk about too.
Sure.
Because it's really interesting that people say, no, I don't trust the medical establishment. What about your doctor? Oh, I trust her.
Right.
You know, it's
right.
like
100%.
Right. It's like,
yeah.
Oh no, medical care. I don't know what these folks are doing. Well, what about your doctor? No, he's great.
Right.
By and large.
Oh my.
Right?
Well, does the name, and you know, I don't want to open up a lawsuit or anything, but does the name Dr. Valicenti mean anything to you?
Right. Exactly.
How many times did you hear the name Dr. Valicenti?
We trusted Dr. Valicenti. We love Dr. Valicenti.
Trusted and beloved.
And which is why I went into the medical field, which is why I became a PA, which is why I became an epidemiologist. It was because of folks like Dr. Valicenti. And even Dr. Valicenti was our childhood doctor. And it wasn't even like he was a pediatrician or probably, he was just it. He was the doctor. He took care of you. He was
the man.
If you were a kid and you needed a cut sewn up, Dr. Valicenti did it. If you were an older person and you had a heart attack, Dr. Valicenti took care of your heart attack.
If you needed to have a baby delivered?
If you needed a baby delivered, Dr. Valicenti did it. So clearly those days are over. Right? Okay. With some benefits. I mean, there's an old saying in medicine, like, I don't know if I 100% believe it, but, like, a bad specialist is better than a good generalist kind of thing. I don't really believe that, but still,
right.
It's just sort of like the sense, like, there's an increasing specialization, right? And you trusted that person.
Yep.
Do you trust them now? Maybe, maybe not. I still think people trust their healthcare providers.
100%.
They might not trust someone who they feel is removed from their daily life. So if you're the director of the Department of Public Health and you tell people that they should get vaccinated, that's a different message than someone going to their physician and their physician saying, listen, Charlie, I know you. You need this vaccine.
Right.
Right. Yeah, really.
Right.
Even then, you're okay to question it. And I'm going to circle back to what you were saying about, like, should we, just unquestioningly accept people's opinions and recommendations, or should we question them? Absolutely, we should question them. Absolutely. But I will tell you this. You will not, and skepticism is healthy.
Yeah.
It's absolutely healthy.
Yeah.
And what I don't think that some folks appreciate, that I appreciate, and it's not fair to expect them to because they might not be exposed to it. It's like, you will never meet a bigger group of skeptics than a group of physicians and academic medical researchers sitting in a room discussing a recommendation or discussing a research proposal or discussing an outcome. Now, they might not be very skeptical about their own results, but somebody else's results, man, they get torn to pieces. So when you say skepticism, I'm like, yeah, of course. I'm trained. I spent 12 years training to be a professional skeptic. That's why when I kind of say, okay, listen, you know what? Okay, this passes the test. At that point, I'm like, okay, I'm done. What I think the danger is that some folks go beyond skepticism into disbelief and cynicism, where they say, oh, and maybe disbelief is better than cynicism, because cynicism means, there's nothing you're going to say that's going to believe you. I question your motives, right? That's tough. That's tough to get beyond. Right?
Well, but I think you have to think about where that's coming from, right? So when you get some of the stuff that's thrown out there, and let's face it, we live in a society that is very much money driven, right? And I think whenever you look at something like what just happened with the COVID epidemic, there was an awful lot of money being made in the healthcare system under the umbrella of the pandemic. And so I think that you do have to be a skeptic, and you do have to ask questions, and you do have to follow the money. And when you do that stuff, I think it leads to more questions, right? It doesn't necessarily lead to answers. And so, when you see, you mentioned, what just happened with the election of Trump, and now there's a whole change of the guard going on. And, he's named his cabinet, and you have appointees that are happening, this week here in January. What is your sense of the nominees that he's named? Do you have a feeling of maybe this will be good, a shakeup, change is a good thing, or is it one of angst and anxiety and, oh my God, what are we doing here?
You know what? My sense is that there is a need for a shakeup. There's a need for a change, clearly. And I think that the majority of the public who voted felt that and said, when I think about this, I don't think to myself, oh, what are these people thinking? What are we thinking? As a nation, kind of thing. I disagree with a lot of stuff, and there are other stuff I'm like, okay, you know what? You got a point. Let's talk about that. I think it gives us an opportunity to look closely at things that we've taken for granted. I think it should. I'm talking from the perspective of academic medicine. Right? Yeah. We could wring our hand and say, oh my God, nobody loves us anymore. Nobody wants to listen to us anymore. But I say exactly. But take a step back and say, okay, exactly what's going on here? Why do people feel this way? Why are they willing to put their health and well-being in the hands of folks who, in my opinion, might not have the evidence in focus. Is kind of a kind way to put it, But this is where we are. Let's deal with what's happening on the ground. I'm reminded of this story. I remember the first time we spoke, I used this word apocryphal, and you're like, Charlie, please don't use words like apocryphal. But it's a potentially apocryphal
That has nothing
story.
to do with you, ladies and gentlemen. That's all me. I struggle with these long words.
No, I need to use these words. They make me feel comfortable.
So apocryphal.
But it's a story that might not be true.
Yeah.
It just might be something that we tell each other. But
gotcha.
when I was actually, even before my doctoral training, I was getting my master's in public health. We were told this story in a global public health course about an effort to introduce milk to a small village in Africa because the children, there was a bone density issue. There was some story that sort of built it up. But anyway, they were trying to introduce milk. And so so the local aid group, the USAID, or one of the aid groups brought, condensed milk to this African village and left big jugs of milk. And they said, listen, give this to your kids because it might have been rickets or something like that. But it was like, give this to your kids. They need this to make them feel better. Then they were going to come back in like 6 months just to test the kids, do bone density measurements. They came back and they noticed that there had been no change in the bone density measurements, but the local villagers had used the condensed milk to paint the walls of their houses and huts. And so there was like, what is wrong with these people?
Right.
We're giving them this life-saving, milk, and they're using it to paint the walls. Until someone looked at it a little bit more closely and spoke to the villagers and said, why did you use this stuff that we gave you to drink to paint your walls? They said, because it made us sick. And it ended up that the story was that the villagers had a high prevalence of lactose intolerance, right? And so they were drinking this stuff and not feeling very well, but
right.
They were like respectful enough that they didn't want to insult the folks who were giving this milk, and they wanted to do something with it. They were like, they went through the trouble of giving us this milk. We can't drink it. We're not going to drink this stuff, but what can we do with it? Let's use it to paint our walls.
That is hilarious. Now, right? We're looking for the village. What village are you looking for? Farty Village. Farty Village?
Yeah. the white one where they used to have diarrhea. But, we afford that level of respect in global health, right? Shouldn't we afford that level of respect to ourselves? Shouldn't we ask that question about ourselves? Why do folks not want to accept these healthcare interventions? Is it the message that's wrong? Is it the actual intervention that's wrong? What's going on? Right? Exactly. I think we should take that approach and say, because I think people are rational.
Yeah.
I have to believe people are rational. They work with the best evidence that they have. I might be wrong. I think there's an emotion. Maybe there's more emotion involved.
Yeah.
Than I'm giving it credit for.
Yeah.
Maybe we differ that way.
I think everyone is different though. So when we were going, and I'll be honest, even for me, I kind of flip-flopped on my view of the vaccine.
Okay.
When we were hit with it and I was diagnosed with COVID, kind of like the first week in March that, all hell broke loose.
So was I. Yeah.
So it was like, it was just before St. Patrick's Day, right? That the president came out and made an announcement on like a Sunday. I was diagnosed like that very weekend.
Right. And I could actually probably tell you where we both got it. Because I think we were both in the same room.
Oh no, I know where I got it. I got it from Maria.
Yeah, but anyway, and Maria teaches. Yeah,
maybe Maria got it from you.
Yeah, but who knows?
Where do you think you got it?
I think we were all together at a wake.
No. So I think
maybe
that,
not. But I got it like right after that.
Right after that.
Yeah.
You might have gotten it from us.
Yeah.
Who
knows?
We actually. So Maria's a speech language pathologist. She works with special ed kids,
right?
And
Sure.
they're coughing and sneezing all the time. And she picked it up, brought it home, infected me. We went to a party that same weekend. We were the super spreaders at that event. Infected
I know.
unbeknownst to us.
We didn't know at the time, yeah.
And so, but getting back to point.
Yeah, you were talking about like vaccination and COVID, right?
We have a painter that we use on Long Island, and the guy is he's an amazing specimen of physical fitness.
Sure.
There's not an ounce of fat on him, doesn't put anything bad into his body. And this may be a year or so after the initial outbreak, he was like, I'm not vaccinated. He said, I wouldn't put that into my body. And he strikes me as someone who is very knowledgeable in this area, not only because of the way that he looks, but just talking to the guy, he knows an awful lot about just obscure health stuff, like fluoride in water, not being necessary, just stuff like that. And so I think when the vaccines first kind of came out, I was fully for it, saying, we can't shelter in anymore. This is at least the mechanism for us to, get back to, being able to mix and mingle and some kind of normalcy in our lives. But then there was a contingent of people that were kind of, I'm going to say they were outliers, who were like, no, like we don't believe in this. And I guess there are degrees in everything. I'm sure there were some non-believers that, maybe shared your level of experience and are super informed and, knowledgeable on the matter. And many others, I'm sure, that were just, they just didn't have a good feeling about it, or
Gotcha.
they weren't, they felt like it was a conspiracy.
They were going
right?
on their gut. They were going on their experience, and that's useful to sort of think about it that way. This kind of goes back to what your initial question to me about epidemiology and what drew me to it and what sort of. And I said, sort of like that. Oh, well, epidemiology is the foundation of medical science, kind of thing. I don't think that really. I don't think that really sort of covers what I'm trying to get at. It's an uncertain world, and I think a science like epidemiology, I think medical science in general, combined with things like pathophysiology and lab science, taken together, afford us the only certainty we can aim for these kinds of questions, for these health-related questions. And it's been proven time and time again. I mean, and this is a good opportunity to say this, and I will say this forever, based on, I've been doing this work since 1984. And based on all those years of work and based on my training and based on everything I know and everything I believe, vaccines are effective and safe. They are effective and safe. Generally, they really are. Are there occasional bad outcomes with vaccines? Yes, they're very rare. Are they less rare than getting the disease? Absolutely not. Are you much, 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 much better off getting the vaccine than getting the disease? Absolutely yes. That's clear to me. That's absolutely clear to me.
Okay.
I have zero doubt about that. The question is, how do you get that across to folks who might not have 40 years of experience and, decades of sort of a training? It's kind of unfair. And we get back to that, okay, well, I'd hope you trust me to tell you that, listen, it's safe. It really is. And we get into a bunch of different, so for vaccines, now.
Well,
that's
hold
sort
on,
of like my blanket statement.
So two things that I want to just touch on there. So I think with anything, you have to kind of look at what am I trying to say? Kind of, I guess, the consequences of your actions, right?
Right.
And I think when we look at COVID, and originally we were thinking, hey, this is a death sentence,
Right.
then clearly there are benefits in taking a vaccine.
Sure.
But I think what we know now, looking, in hindsight, is, well, most of the casualties were dealing with comorbidities, or they were, extremely overweight. They didn't take very good care of themselves. They, were somehow immune compromised. And so for those folks, it is, absolutely in their best interest.
Now we're getting to something really interesting. Yeah, that's a good point.
But for healthy folks, for people that did take care of themselves, that were fit, yeah, there were casualties, but they were few and far between. And so I think the question becomes, well, if I'm a younger person that never had any health issues and I'm taking care of myself, and yes, there is a risk for getting COVID, but if I get COVID, I'm likely going to be able to get through this. It's going to be like a bad flu. It's going to be miserable, probably. There are no guarantees.
Right.
But for me personally, it's worth the risk of not being vaccinated because I'm going to be okay here.
Now now you get into something really interesting. I think you're actually getting down to like sort of like the core of the issue. First of all, what you're talking about is like risk benefit, which is basically the the basic balance in all healthcare decisions.
Yep.
What's the risk to me? What's my benefit? Kind of thing. And your risk benefit may vary compared to my risk benefit.
Yep.
Right?
Yep.
So, like, for example, like the Surgeon General just came out with the alcohol recommendation, where he basically said that—
I don't want to hear it.
No, he basically said, do not drink. He basically said
Don't do
a single drink a day is deleterious to your health.
I'm fucked.
But
yeah.
Is that recommendation the same for you and for me? For me, at my age, with my risk profile, maybe I shouldn't drink.
Right.
Maybe I should make that decision.
Right.
If I was 20 and had a different risk profile, maybe drinking, actually the trade-off of the small risk associated with drinking, moderate or sort of like social drinking, is balanced by the enjoyment I get from it. Mm-hmm. So so like that risk benefit thing varies by person.
Yep.
There is not a movement, but there's a sense or certainly like maybe a movement in clinical research to try to address these kind of personal level risk estimates. It's like personalized medicine, individualized medicine. From my generation of folks who trained in population health and epidemiology and public health, it's a very different mindset. We're used to looking at thousands and thousands of people, right?
Yeah.
Like for me, the idea that you build a single bridge and say, yeah, it's going to work is mind blowing.
Right.
It's like, I want to see 1,000 bridges kind of thing before I'm like, okay, you can build that one.
Right.
But there is this sort of so you're absolutely right that it varies. Now, the second point, and I think this actually gets to like what you were mentioning, to remind you about talking about masks. Let's get to that. The question is, are vaccines effective? Are masks effective? Versus, are vaccine mandates effective? Are mask mandates effective?
Right.
And I think those are two different questions.
Okay.
Vaccines are effective.
Okay.
Vaccine mandates, maybe less so, right?
Well, expand on that.
Okay. Well, let's talk about masks. Masks, I think, are a little bit easier to sort of because vaccines are effective, and vaccine mandates have this element of herd immunity that we need to talk about. But say masks. A mask will protect you from particulates. It will, but you have to wear it correctly. It has to be the right kind of mask. And it has to be used consistently.
So it can't be like a bandana tied around the back of my head, like I'm a bandito.
It's not going to protect your chin or on your nose with your mouth open, kind of thing. It's like there's something involved in the effectiveness of masks, right?
Right.
So I take 1,000 people and I tell them you must wear a mask, and I take 1,000 people who don't, and like the effectiveness of masks might get diluted by people not using them correctly, people not using them at all, that kind of thing. So I think it's been kind of shown that the mask mandates varied. It wasn't that the masks don't work, because I'm telling you, masks work pretty much. That's why surgeons wear them. Is
that why?
Yeah, because we know they kind of work.
Right.
Because you don't want your surgeon walking in saying, "Hey, how you doing? Let's do this," and just whatever, just sort of clapping his hands. Gloves work, masks work, cleaning things work.
But that's how back in the day, they, prior to a surgeon sterilizing their hands and going from patient to patient,
right,
a lot of people died that way, right?
Yes, Ignaz Semmelweis proved that.
Ignaz Semmelweis.
If you want to look him up, Ignaz Semmelweis was a physician.
Yep.
I can't remember. It was certainly like the late or mid 19th century. He noticed that women who had their babies delivered by physicians were much more likely to get what's called puerperal fever, which is like postpartum fever, where their uteruses would get infected and they would die. Really, when we were talking about how fortunate we are to live right now.
Sure.
We're living at a time where a woman can reasonably expect to have a child and survive. That was not always the case.
Yeah.
It was not the case for most of human history. Now, Ignatz noticed that women who had their babies delivered by physicians were likely to die. Women who had their babies delivered by nurse midwives were not.
Wow.
And he was like, well, there must be a reason.
Correlation.
This is proto-epidemiology. This is why I love epidemiology.
Yeah.
And so he said, well, there must be a reason for this. What he found out was that the physicians were going directly from cadaver anatomy labs to delivering babies.
What's wrong with that?
At a time when no one really washed their hands or changed their jackets or wore masks or anything like that.
Right.
And they were infecting their patients. Now, this was before there was I think it was before there was like a sort of like solid idea of germ theory. But he knew, listen, you know what? We're just looking at these populations. There's something different going on. And the biggest difference he could find was that the nurses wash their hands.
Ah, wow. Something as simple as that.
Exactly. To us, we're like, well, of course they wash their hands. But back then, no, that wasn't the case. So,
and you can make a correlation then and say, well, masks is just, it's part of that.
It's that
process.
idea. So then there was like this sort of expansion of that thinking to say, well, if washing hands makes a difference, then maybe breathing, and then breathing on people makes a difference. Maybe clean clothes make a difference. Maybe washing the table in between each procedure makes a difference.
Right.
And they did, and we owe a debt of gratitude to a nursing profession for a lot of this stuff. But yeah, it's like the things that we kind of take for, we know they kind of work. Now, then the question became, okay, will everybody be required to wash their hands? And let me tell you, apparently there was some pushback from the physician population saying, wash my hands?
Right.
I think not.
Right.
Senior, Dr. Semmelweis.
Right.
Yeah.
Right.
Yeah. Like I remember I was saying how we go through these cyclical periods where that was a time when knowledge was advancing.
No, and if I have to think about it, physicians, dentists, they're pretty badass people back in the day.
Sure.
Like you're operating on people without anesthesia,
right?
Without all of now I think we tend to think of physicians, surgeons, dentists as kind of prissy boys,
or they're considered sort of like upper class, upper middle class kind of folks. But
back in the day, I think these were some pretty.
You lost one wire.
It's okay.
Yeah, we're good.
Yeah, we were pretty rough and tumble kind of people.
Right.
Or I'm saying they were rough and tumble kind of people, and now I think there's this kind of stigma of they're a bunch of prissy boys.
Well, I mean I think what if you're getting at this idea of elitism, right? I don't want to listen to the cultural elites. There's a buddy of mine, he's a lawyer. He says, yeah, everybody's anti-elite until they need surgery. Then you want the most elite person you could find. Then you want to go to a place like Columbia, Hopkins, Stanford.
Right.
Then elitism is pretty good.
It's like I'm not a practicing Catholic, but when the chips are down, I call God.
Exactly. Yeah,
Jesus,
exactly. You want the most. Who's the most elite of them all, right?
Exactly.
Yeah. So there is this sort of sense of anti-elitism that's running. This anti-elitism is a populism. It's certainly running through society. We're certainly seeing. And again, I would be wrong to say that the folks who feel that way. Now, listen, some of them are, it's very difficult to understand their, what their opinions are.
Yeah.
But most people are just sort of I'm just asking a question. What I'm getting back to is this idea. It's okay to be skeptical, but don't be cynical. Don't, accept that, there is evidence. So this discussion about COVID vaccines.
Yeah.
It's kind of interesting. I have a group of friends of mine. I love them dearly. We've known them since high school. And we have a chat sort of thread that's been going on for 10, 15 years, the same thread. And they had a lot of questions about COVID vaccines. Still do, actually.
Okay.
And I keep on hitting them with the evidence. And it's kind of interesting. But I reach the point inevitably where I give them enough evidence. They're like, oh, I didn't know that. Okay. All right, okay. They're saying, well, what if? And I'll say, well, then this. But what if? And, well, there's this. And I'm saying, well, it could be. And I was like, no, there's this. And then they're like, okay. And then literally like 3, 4, 5 months go by, and they're kind of back at like, I'm not sure about these vaccines. I'm like, okay, we have to do this again, Yeah.
Back up a little bit. And so go back to masks.
Right.
So I remember seeing videos of, these fools on Facebook and Instagram or whatever, and they were doing tests with masks in like cold air.
Right.
And they put a mask over their face and they'd breathe in and out and you'd see this puff of air and they'd be like, not effective.
Right.
So what is the purpose of a mask? Is it to protect the mask wearer or is it to protect others?
Both.
Both.
Absolutely both.
In terms of efficacy, is it more one way or the other?
My sense is there's not the thing about masks, with viruses is you could make the argument, oh, well, the viral particles are too small for the mask. And then I'd say, okay, well, then it depends on the type of mask. That's why they have like those N95s versus like the cloth masks. But even the cloth masks will have some effect. Exactly. It depends on the kind of bug kind of thing.
And what about the wearer of the mask? If the mask wearer has a beard versus
absolutely makes a difference.
It does make a difference.
It absolutely makes a difference. Yeah. I mean, like surgeons that like folks have to be fit for masks. Like masking in healthcare institutions is not as simple as just giving folks, okay, here's a mask, put it on. For the folks who work in the healthcare institutions, there's fitting processes going on.
Yeah.
People need to learn how to actually put the mask on their face, kind of thing. There's a lot involved. I think the public health community did a very poor job around masking. I do.
Okay.
Well-intentioned, but clearly didn't turn out the way, and ended up sort of like causing more folks to question public health expertise than what they accomplished through the mask mandates kind of thing. The truth is, like if both of us are wearing a mask, we're in a pretty good position where if one of us has the virus, we're not going to transmit it. If only one of us is wearing a mask, that effectiveness gets cut by half. Maybe not kind of thing.
Right.
If neither of us are wearing a mask, it definitely increases the risk. So you're better off, like one is better than the other. Then you have all these other variables. You have to use it correctly. You have to use it consistently. You have to use it, you have to have the right kind of mask kind of thing.
Right.
Now, I think it was asking a lot of people.
Yeah.
And asking a lot of this particular kind of technology. But like you said, it was a scary time, man. People were thinking about, I think what folks forget, maybe they forget, maybe they don't, but I remember, my office is at Bellevue. And for folks who are listening, like Bellevue Hospital in New York City is sort of like the flagship hospital for the city hospital system. And it's where the medical examiner is, the city medical examiner is. And I remember driving into work during the pandemic and seeing these refrigerated trucks outside the hospital because they had run out. I mean, it was a scary time.
Right.
It was a scary, scary time.
Yeah.
It was, they couldn't bury people fast enough.
Right.
That's the truth.
Yeah.
That's the reality. I saw that with my own eyes. So it was a scary time. And I think public health folks were saying, what can we do? We have nothing. Right?
Yeah.
And
I think that's what
Yeah.
people don't kind of absorb. We were ground zero here in New York for COVID. And I remember seeing those reefer trucks. And I know that there was a hospital in particular in Brooklyn that had them lined up.
Absolutely.
And it was just...
My hospital, Elmhurst, where I used to work, was crushed.
Yeah.
Devastated.
Right.
It was awful to see. Yeah.
Right.
It really was. And at the time, I was thinking to myself, okay, if this is the least I could do. Now, we're getting into this, and I'm glad you asked this question.
Yeah.
You just said, does it help me or does it help you?
Right.
Because now we're started getting into the idea of like, okay, individual versus communal behavior.
Right.
Right?
Yep. Yeah.
And now where do we come down on that? Now that is really sort of like, judgment. Right.
Right.
That, yeah.
Well, so take me back though, because there's there's vaccine mandate and there's mask mandate. Where do you fall on either of those?
I mean, I came up and I fully believe in the effectiveness of vaccine mandates. I really do. I
Okay.
mean, I think it should be like it's always been. It should be within individual ability to accept the vaccine, but I think it's absolutely within the purview of healthcare administration, of government, to impose that kind of behavior on the part of their citizens. Or if you choose not to have the vaccine, that you
Go live in the
are
mountains.
Limited. You're limited in your ability to. I think what we did was like sort of like public health 101 in terms of like, you know, vaccines. You know, like
Right.
like the idea of like quarantine, right?
Yep.
It's an accepted part of public health. Now, are we going to get rid of all this now? Are we going to lose all this hard-won information and knowledge because we've forgotten what it's like to have deadly infectious diseases in our, you know, running through our population?
Right.
You know,
Yeah, it's not an easy question, right? Because on the one hand, you have freedom and liberty,
right.
but on the other hand, you have what's in the best interest of the public,
Right,
And
right.
so, you know, you have to look at those things and say, well, in order to safeguard the public, we must impose a mandate. And I truly think that that's what was at work with
Right, exactly,
with
yeah.
the vaccines. And in hindsight, I'm going to look at it and say, well, I don't think it was executed flawlessly. Certainly, I think the delivery and the dissemination of quality information needs to be better.
Right.
But at the end of the day, there shouldn't be this bullshit back and forth debate for people who are not in the know, who are just kind of pontificating based on, you know, their experience. We need to hear from almost like a trusted source that is unbiased, that has no financial motives, to be the go-to to say, this is what the evidence says. And so I don't know if you're familiar with Marty McCary, Dr. Marty McCary's work.
You've mentioned the
And
name,
so
yeah.
he's the incoming FDA lead of the FDA, I think.
Is that okay? So he was a physician in Florida,
Johns
right?
Hopkins.
Oh, he was at Hopkins.
Yeah,
Oh, that's right.
Johns
right,
Hopkins
right,
trained
right.
oncologist,
Yes.
brilliant guy,
Right.
and you know, has authored a number of different books. One is Blind Spots, where he talks about some of these things and some of the studies and the clinical trials, and how, you know, sometimes the numbers are manipulated.
Yeah, I mean, now we get to
well,
the question of skepticism versus like disbelief.
so
right?
so there's one thing that he came out with very vocally about, and that was he was not comfortable with the guidance to administer vaccines to children.
Ah, okay.
And his guidance was led by the studies, and the studies they didn't pass muster with him to feel comfortable enough to say, yes, vaccines are safe for children. And I don't know if that's something that you can.
That's a voice that should be in that room. Remember, I told you about that. I've sat in those rooms,
Yeah.
a bunch of times for like review panels and review groups and
Yeah.
recommendation panels, and that's a voice you need in that room.
Mm-hmm.
Honestly,
Yeah.
that's a reasonable observation. It absolutely is.
And why
And
wouldn't you
now-
want to get to the bottom of
to
that,
me,
right?
To me, it's actually kind of analogous to the idea of flu vaccines for kids. There is like you remember we were talking about like Maria,
Yeah.
right?
Yeah.
Now imagine now kids can get the flu, it's fine. They're okay.
Yeah.
You know?
Yeah.
Old people get the flu it could be passing into the celestial beyond. It's like,
We all got to go sometime,
yeah,
Charlie.
exactly. But
Yeah.
in public health circles, there was an argument that there should be a mandate to vaccinate kids, school children,
Yep.
to prevent flu in older adults.
Okay.
Again, that's a matter of sort of like debate,
Right,
right? You
right.
know? I mean, because now what you're saying is that all the risk is on one group,
Right.
and all the benefit is in another group,
Right.
right?
Right.
Is that the appropriate mix of risk benefit? Now, clearly, that physician that you mentioned
Yep.
said, no, that's not fair.
Right.
That's not a fair that's not an ethically sort of like, fair balance of
Right.
risk and benefit.
Right.
And you could kind of make that argument. I don't know the numbers for kids well enough. I do know that the APA, the American Pediatric Association, and most pediatricians recommended kids getting vaccinated
Right.
because it's like they basically said, no, we've seen kids with COVID. It's no fun.
Right. Right.
Right. Kids can get sick really badly. But I could kind of see the debate about mandating it for kids in that case.
Yeah.
I think it's a little bit different in the setting of of like a deadly epidemic like COVID, right?
Yeah.
Like again, I keep on thinking about public health really within our lifetimes, where there would be a vaccine, like there would be like a measles outbreak or a smallpox case,
Yeah.
and folks would line up for blocks
Right.
to get vaccinated
Right.
because there was a strong sense and memory of the danger and the horrific nature of these diseases.
Sure.
That, I think, is what we kind of lose, I mean, like when we're talking about the vaccine debate, right now, people kind of lose the idea that measles, for example,
Yeah.
kills children.
Right.
Measles vaccines, by and large, don't.
Right.
They might make them sick sometimes, pain in the arm kind of thing.
Right.
Some of the stuff that folks think are associated with measles vaccines are just absolutely not.
Right.
There is, again, to your readers, no risk of autism from measles vaccines. There just isn't. People who believe that
Yeah.
are misreading the evidence.
Okay, so I'm going to push back a little bit there.
Okay.
And I can't obviously draw a line between vaccinations, MMR, vaccine, and autism. I can tell you that the rate of autism in this country has skyrocketed.
True.
And that's coming from somewhere. And there seems to be a correlation between the time that autism is identified correlating to shortly after these vaccinations. And I think it's worth looking into. I'm not saying
Absolutely.
that. I'm not saying,
Again,
hey,
that's the skepticism.
but we went
thing.
from
That's fair.
1,500 children per birth being diagnosed with autism to now it's in the 30s in
Now,
California.
what if I told you that it has been looked into and that there has been no shown association, and that even despite this lack of association, the small risk
Right.
associated with one of the ingredients, the thimerosal, thimerosal was removed,
Right.
and yet there still was this increase in autism diagnoses having
Right.
nothing to do with thimerosal at all.
Right.
And I could say, well, you know what? I mean, there's been an analogous increase in autism with the introduction of ultra processed foods. There's been you could look at any number of things
Sure.
that have that were introduced at
Sure.
around the time that autism started to go up.
Right.
I here's the thing, right? I get it. It's kind of scary. You're
Yeah.
taking something and you're putting it into your body.
Yep.
The thing is, this goes back again to the question of like epidemiology, how it helps us shine a light in the direction in which we should go. Because I give you the MMR vaccine, right? The next day you get a fever and you end up in the hospital. Of course, you're going to think to yourself, it had to have something to do with the vaccine,
Sure.
right?
Yeah.
And maybe it did. How do I decide whether the vaccine had anything to do with it? Well, there are ways we could decide. I take 100 kids and I give them the vaccine. I take 100 kids and I give them water.
Placebo. Yeah.
Right?
Yeah.
And I look at them. And what I find is that there's absolutely no difference. Then you say, okay, well, you need to do it with 1,000 kids. I do it with 1,000 kids. You do it with 10,000 kids. I do it with 10,000 kids. You need to do it with 100,000 kids. I do it with 100,000 kids. That's kind of the level of evidence that we have for vaccines.
Right.
And autism outcomes and stuff. These comparative studies. Now, is it 100% that someone who gets a vaccine is going to have nothing wrong with them that's due to the vaccine?
Right.
No.
Right.
But again, is it better to risk that and get the benefit of not getting measles? Again, to me, that risk-benefit balance is clearly in the direction of vaccinating.
Gotcha.
And that's sort of like, that's the decision-making process. I still remember, this brings it down to sort of like the individual level, working clinically.
Yeah.
Right? You're in school, and it's very clear. There are these symptoms. There are these signs. There are these blood tests. That's the diagnosis. This is the treatment.
Right.
Until you go out into practice. And then suddenly it's a lot less clear.
Right.
Some people, clearly they're sick.
Right.
But
looks like a duck, talks like
exactly.
quacks like a duck,
right.
walks like a duck. It's got to be a duck, right?
But
No, it's not a duck.
I still remember, something. And now, like I said, I was a PA, right? I was a physician assistant.
Yeah.
I worked 18 years in emergency medicine. When I was out there, 16 or 17 years, having done it for a long time, I was pretty good at it. I'd seen a lot of sick people.
I would imagine.
Yeah, and I was actually pretty decent at it. But every once in a while, there would still be a case where I'd be like, I don't know what's going on with this person.
Right.
So I go to my supervising physician, who may have graduated a year or two ago,
Right.
and had been at it for like 3 or 4 years.
Right.
And I remember going up to some of them, and they would see me coming, and they were like, no, please don't. And I would be like, I don't know.
Right.
And she would say to me, like, if you don't know, how am I supposed to know?
Right.
And I would say, the problem is, you have to know.
Right.
I don't actually have to know.
Yeah.
I have to know enough to go to you.
Right. And they're like, no,
and
no,
I don't
no.
know what's going on with
They're
this
like,
patient.
check, please.
Sometimes these decisions are made with imperfect evidence.
Yeah.
Same thing with this vaccine business.
Yeah.
Sometimes they're made with imperfect evidence. I think the evidence on the safety of the MMR and measles vaccines is rock solid. I absolutely do. I understand. The problem, again, is that there are folks that will look at it and notice some quite legitimate anomalies in the data, and then use that to basically say, no, this is not safe, or no, this is not acceptable.
Yeah.
When in reality, if you kind of look at the totality of the evidence,
Yeah.
again, I don't think any individual should make that decision.
No,
I don't think any individual can.
I got you.
I
So
think you
here's
need to
the question,
you
though.
need, I'm sorry, what's his name? McGarry? There was
Dr. McCarry.
McCarry.
Yeah.
That guy should be in the room. Absolutely.
Yeah.
He's that's a legitimate observation, But there need to be other people in the room saying, you know what, you're right about that, but that's.
Yeah, but the other thing is, I think sometimes we just don't know. Like, you gave the analogy of, all right, so we have 10 subjects, we have 100, we have 100,000 subjects.
Right.
Like, we're drawing you a picture here, stupid. Like this,
Yeah.
this is like, this works. You ever misplace something and you look everywhere for it and you can't find it, and then you look again and you find it? It could be a case of that also.
How so?
Well, so it could be that it's right under our nose, and we think we've exhausted every possibility. We've done all of these studies. We have hundreds of thousands of participants in our search to prove there's no correlation, blah blah blah, but yet there is.
Right.
And so all I'm saying is, we should never stop searching and questioning, And I don't think we should hang our hat on the fact that we have this mountain of evidence. I certainly think it's a good start, and it counts for something, for sure. But then I would say, well, what about the correlation, though, of these parents that have this beautiful child, infant, that is engaged and happy and smiling and interacting, and they go for this vaccine, and within a short period of time, it's like a switch went off.
Right.
I don't think that could be ignored. And the question might be, well, maybe space the vaccines out further apart. Maybe have the vaccines administered when the child's immunity or systems are more mature. I don't know, but
You know what? I mean, if the question is, could we be wrong? The answer is certainly. If the question is, well, have we been wrong in the past? The question is absolutely.
Mm-hmm.
We've been wrong. We can be wrong.
Right.
The case you bring up, that of an individual child like that, it's a tragedy. But then the issue becomes, how do we balance that individual observation against that mountain of evidence? And at what point is the evidence sufficient? Right?
yeah.
Now, if you were to say to me, these studies are flawed, if you were to say to me, these studies are misinterpreted, then I would be like, okay, we need to take this seriously.
Right.
My strong sense is that the studies are not flawed.
Right.
That, in fact, the flawed studies are those that demonstrate some sort of association with bad outcomes, like autism.
Yeah.
That's my sense of it. And and we could talk about like
Yeah.
we get things wrong in medicine, and folks are right about that. I mean, they I think they deserve to know it.
Right. No, and what I'm saying is, look, I get it. Like, from a statistical standpoint, you look at the numbers and you're like, Ray, it's like, it's like the odds are literally like a fucking lottery ticket.
Exactly.
Right.
Yeah.
That this information is off. But are we looking in the right place? We may be in the ballpark, right? Looking down the road of MMR vaccines, for example.
Right.
We may be in the neighborhood, but we're cold. We're not looking at what we need to be looking at. And I'm just pontificating here.
No. I understand.
I'm a dummy, right?
This is exactly what I was talking about. We need, this is the discussion that's going on now in healthcare, in our society. This is exactly what we need to talk about. You got a guy like me comes in and says, no, it's shown, it's proven.
Right.
And you got a guy like you say, well, I'm not sure because I've heard this, I've seen this, I've seen that.
Right.
I think at a certain point, you have to accept the evidence as it is.
Yeah.
Unless something, what's one way to think about it is like, there's this is so in the weeds, but I'm going to do it anyway.
Do it. Go for it.
There's a statistical approach called Bayesian analysis.
Okay.
Right? Now, the way we actually do statistics, it's your fault. You mentioned statistics. Okay?
Sorry, folks.
Right. But the way we usually do statistics is we say, okay, we have this null hypothesis where really we talk about skepticism. This is how statistics is done. We have this idea.
Right.
And instead of like saying, okay, we want to prove this is true, we kind of prove that the null is not true.
Okay.
It's weird. It's a weird way to think about stuff, but this is the way this is like sort of like the way we're kind of trained. There's this hypothesis, this null hypothesis that there is no association.
Right.
How much evidence, what's the probability that the null hypothesis has been, is not true kind of thing. And that's what sort of like this statistical test is. But there's a bunch of people that say, that's kind of convoluted. That's a weird way to think about it. And it's this Bayesian thing. And Bayesian thing is actually really the way human beings think.
Right.
It's like I go into it with this idea. I have a gut sense about something. It's called your prior probability, right? So your gut sense is, you know what? I think that there's something going on with vaccines in kids. I do. So then you take that gut sense and you add to that what's called the likelihood, which is all the evidence, the probability that it's true.
Yep.
And you combine those together.
Yep.
what's at the end is called your posterior probability. It's the combination of your gut sense and the information. And it basically says, okay, listen, you know what? Here is the probability of this event occurring. So, my gut sense is, you know what? Like if I were to ask you, on like the odds. What are the odds? What are the probability that vaccines are? Let's just like limit ourselves that the measles vaccine is associated with autism in children. And it's just fair enough. Like,
Sure.
what do you think? What do you think about
25%?
Okay, so you have that 25%.
Yep.
Probability
Yep.
that they are associated with it. And that's based on your reading, folks you've spoken to, your understanding, just sort of like who you are,
Yep.
Your judgment kind of thing. Well, in Bayesian probability, you combine that with the evidence and you say to yourself, okay, well then what is the actual prevalence? What is the actual incidence? How often does autism occur in children who are vaccinated compared to children who are not vaccinated? And that's a number. That's
Right.
like yours is 25%.
Right.
And the likelihood is something like 0.0000. I'm just making this
Sure,
part
of
up.
course.
Okay, this is not what
I
it
made
is,
up 25%.
Right, exactly.
So
Yeah. No, but your prior
Yeah.
probability, just making it up, that's valid in Bayesian analysis. This is what I think. This is what I believe.
Okay.
Right?
Yep.
So then it's like 0.0000000001.
Right.
You add those together
Yep.
in this Bayesian,
Yes.
context.
Yes.
And you end up with this number that says, well, this is based on your
Presumption.
your prior probability and likelihood. Here's what we think the actual thing is, right?
Right.
And I love Bayesian stuff because this is the way clinicians work. You come into a room
Right.
and you say, my stomach hurts.
Right.
And I think to myself, okay, well, it probably just has like stomach flu
Right.
kind of thing.
Yeah.
Let me get a test, get a blood test. Blood test comes back and like one of your lab values, like amylase or pancreatase, is elevated,
Right.
right?
Yep.
All of a sudden, my idea about stomach flu is wrong because I've got this evidence,
Yep.
that maybe there's something going on with the pancreas. So then initially, my prior was pancreatitis, 0.00001.
Right.
Amylase elevated, suddenly pancreatitis, 70%.
It's a little bit of a difference.
Yeah,
Right.
exactly. The evidence makes a difference
Right.
in my assessment.
Yeah.
Then I base my treatment.
Yeah.
I might decide to do like a sonogram and a bunch of other stuff. That changes. At a certain point,
Yeah.
I say to myself, this is what it is,
Yeah.
and we're going to treat this person,
Yep.
right? Apply the same thing to like population health.
Yeah.
To at what point do I say, this is what it is?
Right.
I'm going to treat people.
Yeah. No,
You
I
know,
get it.
right?
Well, so in Dr. McCarry's book Blind Spots, he talks about a bunch of stuff that's been widely held in medicine that are no longer true.
That's great stuff, and that's fun, and that's true. Not
And
fun,
so,
but it's true.
yeah.
I could tell you horror stories. I used to teach. Anatomy and physiology to college students and
Right.
to PA students. And I used to say, I remember the first class I took in pathophysiology.
Yep.
The physician came out and said, "Listen, I'm going to tell you a bunch of stuff. There's a good chance that about 25 to 40% of it is wrong." The big problem is I don't know which 20 to 40%. And things change and they evolve. Like
Right.
there used to be there are these stories, this thing called portocaval hypertension. It's a big name. Basically what ends up happening is the pressure goes up by your liver. Folks who have alcoholic cirrhosis get it. But the pressure goes up and the vessels in your esophagus get big. And sometimes they get so big that they start to bleed. It's the scariest thing in the world. Patients come in. It is terrifying.
Right.
They're throwing up blood. It's a deadly kind of thing. So what they used to do is this surgical procedure called a portocaval shunt. It's like heroic medicine kind of stuff, where they would just go in there and basically take the pressure off the portocaval system. You don't need to know the anatomy. These are just words kind of thing.
Right,
But it was
right.
this sort of heroic surgical procedure.
Yeah.
And then take the pressure off and people would be better,
Miraculously
kind of thing.
saved. Yeah.
Until someone said, we really should look at this, because this is based entirely on sort of like clinical practice, surgical practice. Surgeons would do it and say, people seem to get better. And then a group of surgeons, someone said, we should really look at this, because there's another treatment where you just sort of like use ice water in the, just basically ice water lavage kind of thing to like shrink the vessels themselves. But, which one of these actually works better? And what they found out was that portocable shunts, this heroic surgical procedure, killed more people.
Oh, wow.
Than just sort of using ice water in an NG tube.
That's crazy.
Medical practice was wrong for a long time.
Right. Right.
Radical mastectomy versus lumpectomy.
Yep.
We learned something. That was in our lifetimes. That was in the New York Times. I remember when the New York Times came out and published that study about radical mastectomy versus lumpectomies.
Yeah.
There are any number of things where we've learned stuff.
Yeah.
But there was always a question.
Right.
Right? You go into it, there's a question. It's a good question.
Mm-hmm.
The question is, there's not sufficient evidence to justify this approach. But there are any number of medical practices and public health practices where I would argue there is sufficient evidence.
Yeah.
That questioning this, once we have all this evidence, is, misleading at best and dangerous at worst. Now, that said, we get back to this idea, and I think this is kind of where we're going as a society, this idea that like what works for the population doesn't work for me.
Yeah. Well,
is that possible? Sure.
Well, but there's that. But Dr. McCary specifically talks about peanuts and children, and peanuts were demonized. You don't give peanuts to children or nuts to infants until a certain age, and blah blah blah. And there was this culture in the 90s, especially, where kids just were not given peanuts. And what was the result of that? The result was a tremendous amount of peanut allergies.
Yeah, I don't know that. I don't know that evidence. I don't know that story in particular.
And now it's reversed, and pediatricians are no longer saying don't give peanuts or nuts to children. One example. Another example that he cites is hormone replacement therapy in women.
Right.
And there was a study that showed that there was a correlation between that and, I believe, breast cancer.
Okay.
And so for years, it was not prescribed by OBGYNs to their patients who were going through menopause. And estrogen is like a miracle drug for someone in that boat, completely changes their quality of life, improves their health in so many different ways. And yet, the study, which was later kind of debunked, was that there was this breast cancer correlation, which they statistically prove in the book. You'll read it. It was not accurate. The study was flawed.
Right.
The numbers, and I don't know, it was something about a 0.1. There was a 1 in there, and
I'd love to read that. Absolutely, because I'm not familiar with that literature at all.
Yeah,
and not being familiar with it, and knowing that Dr. McCary is, he's a reputable, physician and researcher, I would accept that. I would say, okay, that's an issue. Although I wouldn't be surprised. I mean, we get things, like I said, we used to yank out tonsils. We used to put in we used to put in tubes in people's ears, and that's not necessarily true. I mean, there's, like one of the, medical science advances and evolves and learns. It does. We don't have it knocked.
Right.
So one of like the absolute truths of surgical care was if somebody had an appendicitis, you yanked out that appendix.
Right.
You operated on that patient. Not necessarily so anymore.
Antibiotics, right?
Exactly. Yeah. You can go to, and so again, but that was someone looking at the evidence and saying, has anyone ever compared this?
Right.
Has anyone ever actually done the epidemiologic study?
Right.
Has anyone actually done a randomized clinical trial?
Right.
And then doing it?
Right.
Like it's amazing how your opinion can change once you actually have some evidence.
Yeah.
It's true. It really is. So I don't necessarily disagree with that.
Yeah.
Where I would disagree is that we don't have sufficient evidence on vaccine efficacy. I would disagree on that. I wouldn't necessarily disagree on mask mandate evidence, I don't think we have great evidence on that.
Right.
There's like some things that I take for granted, and it's weird. This kind of gets to the population individual thing. Let's say let's say for whatever reason I want to hit you on the head with a hammer.
It wouldn't be the first.
So I want to hit you on the head with a hammer.
Right.
Would you rather be wearing a helmet?
Let me think about that.
Okay.
Gee, yes,
Yeah. Now,
please.
same thing. Let's say I put you on a bicycle and hurtle you towards a wall.
Right.
Would you rather be wearing a helmet?
Maybe.
So maybe. So
Right.
you'd think to yourself, well, wearing a helmet while you bicycle,
Yeah,
it's got to be better than not wearing a helmet while you bicycle.
I would think so.
And yet, the actual epidemiologic evidence on the effectiveness of wearing a helmet in a population versus a population not wearing a helmet, it's not that strong. You could talk to any sort of trauma surgeon and say, would it have been better if this patient was wearing a helmet? And they would say, for God's sake, I wish this person was wearing a helmet. But
Right.
yet, if I were to look into the literature,
Right.
the epidemiologic literature, and say, actually, if you look at helmet mandates for bicyclists,
Yeah.
evidence is not, and I haven't looked at it recently, but the last time I looked at it,
Oh, that's
it
interesting.
wasn't as strong as I would like. I kind of think that's analogous to like the mask thing. I know wearing a mask in a sort of lab setting, whatever, is effective.
Right.
Yet if I look at the population level
Yeah.
evidence, not that effective.
Huh.
It's a weird thing that we haven't really
So
explained, I don't think.
let me switch gears.
Okay.
And we're going to wind down. We're running
we
over
could go
time.
on like this forever.
For sure.
Yeah.
But knowing what you know as an epidemiologist, as someone that worked for the CDC, as someone who, as we all did, experienced the
I
pandemic
didn't work
with
for the CDC. I did get funded by the CDC
Oh,
for
I'm
some
sorry.
grants. Yeah, but that's
thanks for clarifying.
Yeah.
Does anything keep you up at night? Do you think in our lifetimes we'll see something like a coronavirus or perhaps worse?
Honestly, nothing really keeps me up at night. I sleep pretty well. It's like that scene in Men in Black where what's his name says, there's always some there's always some alien race about to destroy the earth. There's always something out there.
Right.
So nothing really keeps me up. I think folks are actually okay, sort of like living their lives, things will be okay.
Yeah.
I would think that one of the things that maybe flies too far, and it shouldn't, is we are due for a shift in flu vaccine, and in influenza virus. So
Okay.
like flu, it drifts. It's just like it's like designated like H1N1. It has to do with like the different types of like proteins on the virus molecule itself, but it kind of drifts. It changes a little bit year to year.
Yeah.
CDC does a great job of sort of keeping track of that, and every year kind of saying, oh yeah, this particular flu variant that's coming out of Asia, this vaccine should cover it, kind of thing.
Right.
But every once in a while, and it used to be like every 20 or 30 years or so, the flu vaccine just shifts, just changes. Doesn't just drift a little, just like changes.
Yeah.
And none of the vaccines work for it, and our immune system just is not ready for it.
Huh.
And flu is a son of a gun. It really can be a tough. So we've been due for a bad flu for a while now.
No kidding.
Just the numbers, just from that perspective.
Okay.
My concern would be that if it happens now,
Yeah.
we actually have some decent tools to deal with it.
Yep.
In terms of like mRNA technology and those kind of approaches. Because it used to be tough to come up with a flu vaccine because you had to grow it on eggs.
Right.
That's why mRNA. I was like, come on, man. But I think now with like the level of vaccine hesitancy and skepticism,
Yeah.
if there is a bad shift, if there is a bad vaccine, even the countries that are prepared for it, that have the capability to address it, might not sort of respond the way, that would be kind of scary. that scares me because I'm older.
Yeah. I got you.
All this stuff that I used to not think about at all.
Right.
All of a sudden, the recommendations are like, oh, unless you're older, then whatever.
Right.
And I'm
Right.
like,
Damn it.
don't kind of thing. But like there's always going to be something. I think that like what makes me feel somewhat comfortable.
Yeah.
And this is the truth is I know the folks who work on this stuff.
Right.
They are so smart. They are so dedicated.
Yeah.
We are so fortunate to have them out there. From the physicians and the clinicians and the nurses and the folks who care for you on an individual level.
Yeah.
To the folks who who work for you at public health agencies, they really have your best interests in mind. They get things wrong sometimes.
Yeah.
That's true.
Of course. That's human nature.
But yeah, exactly. But like, I'll tell you, like it was Hemingway who said something like, there is nobody more sort of like enthusiastic or dedicated or something like that than like a young priest, a young soldier, or a young doctor. And I remember that. Remember, like, you were like going, since we're winding up, going back to like, how did you end up there?
Yeah.
I've lived that.
Yeah.
I knew what it's like going out for the first time into like a clinical setting and not believing that they were going to pay me for this.
Right.
To do this. I was so into it.
You were thrilled.
I felt the same way when I moved into research.
Yeah.
And I got a position at like Columbia and I was like in that room.
Right.
I was like, I cannot believe they're paying me to do this. I love doing this.
Right.
It's
right.
like, those are the people that are out there that are like trying to help you. I mean, they love what they're doing. They're all in it for you. Sometimes they get it wrong, and that sort of makes me feel more comfortable.
I could listen. I'm cool with people getting it wrong. Doctors could get it wrong.
Yeah.
Surgeons could get it wrong. Clinicians could get it wrong. I'm cool with that. What I have a problem with is the corruption piece.
I hear you.
And
we didn't talk about that really.
And the money piece.
I know.
And so that's where. You're kind of...
And I might be more naive about that.
Yeah.
Because it's not been my experience.
Yeah.
I've not really... I've come across people that are somewhat venal and stuff. But that's been the exception.
Right.
To me.
Right.
And maybe I've just been fortunate in that way, or maybe I'm just not seeing it. But then it's there kind of thing. But my experience has been like, by and large... Folks are trying. They're trying to do the best that they can.
Right.
And they usually do pretty damn good.
Right.
Yeah. Yeah.
So I'm hearing the overall message is vaccines work, masks work. There's a difference between, a mask mandate and a vaccine mandate. I get all that.
Right.
But by and large, we have incredible technology, professionals that are working on our behalf in a day and age where all of this is possible.
Right.
And, lean towards the side of taking a leap of faith that it's in your best interest to take a vaccine versus being a naysayer. Am I hearing that right?
I think that's fair.
Yeah.
I think that's a fair way to look at it.
Yeah.
And if that's kind of like the message that gets across, fair enough.
Yeah. Cool. Well, listen, Charlie, it's been a pleasure having you here.
It's a pleasure being here, bro.
We have so much to talk about. We didn't even get into your past or how you got here, what you're doing.
We
but
can do another one.
We're going to have you come back for sure. Yeah. But listen, it's been a pleasure. So until next time, folks, peace and love always. Take care.
Bye, all.
So that's it for today's episode of Broken Healthcare. Head on over to iTunes or wherever you listen and subscribe to the show and join us on the next episode.